of staff. Earlier this year, I made a transition to more on the private practice side with several of those other specialists. So I'm still practicing in the Livermore Pleasanton area. I had the opportunity to learn and experience several AI initiatives through Stanford while I was in the previous practice in the hospital. So I'll share my experience today. Thank you so much.
Thank you. Thanks, Chirag. I'm Anurang, Revri. Good morning, everyone. I'm Chief Enterprise Architect at Stanford Healthcare. And can you guys hear me? Is this mic working? Yeah. It is, okay. I have 3 functions at Stanford. I manage the architecture practice. I also have all the integration and interoperability function. And a couple of years ago, we started a new data science / AI implementation group in the hospital. So I manage all those 3 functions. And if you don't mind, Jeremy, I'll maybe just give people a little bit background of Stanford medicine overall, just so you guys understand the context in which we are speaking. So Stanford is an academic medical center, so which means, we have a 3-part mission of education, research, and clinical care. We have 2 hospitals, one that operate independently. We have the Children's Hospital as well as the Adults Hospital. And then within the adult hospital system, of course, we have the School of Medicine where, all the providers are, that's where, the residents, they're part of that. And then they practice in the hospital, and the hospital has the main, campus at Stanford. And then we have a bunch of footprint, Chirag is part of that, and the East Bay, which was the acquisition of Valley Care, and through Redwood City, there's a huge campus there. So we have a significant outpatient footprint, but our main campus is on 300 Thatcher. So that kind of, gives us a good geographical spread, as well as I just wanted to give you guys our mission. We are kind of a mission-driven hospital focused on education and learning.
Amazing. Thank you, Anurang and Chirag, for the intro. I wanted to start off and ask you guys this first question. What would each of you say is your top #1 use case of AI that you've seen at Stanford?
Yeah. We have about 30 odd tools and models out there. At Stanford, and I'll get to your answer. But we haven't rated what the top is, but there are 2 categories of it. We have the standard predictive AI model, that's your traditional AI, that's well understood. We can deploy them, test them, monitor them, like models like advanced care planning for palliative care, or bunch of epic models and those kinds of models. Then we have now more Gen AI kind of models, right, which we are using to either provide different kind of clinical care or reduce administrative burden, right? Like for example, our tool to respond to inbox messages, drafting inbox messages, we just rolled that out. We are also rolling out our ambient AI capability, where it takes the ambient AI capability from Nuance that basically takes notes while you're actually communicating with the patient, so you can focus on actually interacting with the patient, right? So, and then the one that I'm actually super excited about is one of our products that we are putting together, and I know, Sandeep mentioned about large language models, and large language models, provide a lot of general intelligence, but they're not good with specific intelligence. So we are actually, I'm building a product. We just launched, my team is actually launched an alpha version of that, where we can, within the context of our patient and patient's history, actually chat with the EHR and ask it questions, right? Like, this patient had, a history of violent behavior, right, before you admit them into the hospital, right? So you're aware of those kinds of things. Or do they have any allergies or whatever, right? Those kinds of things. So I think that's going to be an interesting sort of automation. We have a bunch of use cases that are coming up that allow you to do automation through that, and I can talk more about that. So that I'm super excited about that. We will be using what are small language models, and the language being the EHR actually, right? And the surrounding documents that support that EHR.
Thank you, Anurang. And I want to pose a similar question to Chirag. Chirag, what are some of the top use cases that you've seen in your work day-to-day? That's the question. So Chirag, what are some of the top use cases that you've seen?
Yes, well, in my previous experience, with Stanford previously, I have seen the model on the hospital side where there is more of an AI prediction model that I have seen, and that involves patients who are admitted in the hospital who sometimes will come to emergency room. They will get admitted to more of a less acuity or a regular medical floor where they are not sick enough to be in the ICU or critical care space, which is where I worked before. And some of these patients who come to a less acuity or medical floors, they have this monitoring through the data that is put in by the nursing staff, which includes their blood pressure, oxygen level, or their breathing rate per minute. And at the same time, all the labs which are done for these patients, x-rays which are done, all the data is also populated in the EHR. So with the data that nurses are collecting, putting in, and the imaging and lab data that's populating together, I've seen a predictive model where the model will tell us, next 8 hours from the time or 6 hours from the time where everything is populated, or which is 24 hours, which patients are likely to be sicker out of, let's say, 30 patients who are on the medical floor. So if there are 4 patients who are likely to be sicker compared to the rest of the 26 out of 30, accordingly the nursing physicians will get alert when they log in the chart of EHR or outside EHR. So that way you can divert your resources, or let's say those 4 patients will need more monitoring every 15 minutes or 30 minutes, or they might have to be transferred to a space like ICU or critical care where there is close monitoring that can be done. There's one model that I have experienced before which is very helpful because when you have 30 patients, you want to know where you need to put your resources in timely manner before they deteriorate, they get sicker, so you can intervene early. And this is something we kind of have learned from COVID, because during COVID we got hit with multiple sick patients coming in, and we only had so many resources to divert, and we have to decide where to put them first in the order of priority. So that's where this model kind of started, and this has become pretty much a standard that I've seen. On the outpatient or office-based model, in my previous experience, I've seen something that that's similar to what Anurang just mentioned, which is node generation of population, whereby we are interacting with the patient. The Gen AI will actually listen to our interactions and populate some of the documentation, which includes patient history, reviewing medications, allergies. If there's a prescription that we discussed, then it will create a prescription order, and then have the entire note ready for review by the time the conversation is done. So when this is done, then overall patients are liking it because we have more time to listen to them, look at them, rather than constantly trying to type in between or trying to document what they are saying, because we always have this little bit of anxiety that we don't want to miss anything that patients are saying, so we can document properly. And at the same time complete the notes in a timely manner. And the patient a lot of times feel like doctors are constantly looking at the computer rather than looking at them. So this really will provide opportunity for us to focus more on patients. So these are the models that I have seen on both inpatient and outpatient side, which have been very helpful.
Thank Thank you. Anurang, question for you. What do you envision is the biggest problem that AI in healthcare, healthcare professionals and AI will help solve in the next 5 or so years? And what do you see as the biggest obstacle that those healthcare professionals will face when trying to solve that problem?
Yeah, maybe, I should take the problem first, that way we can leave things a little optimistic and then actually. So I think the problem, I think Sandeep mentioned one, which is the quality of your data, right? Do you have the data, and do you have the data organized properly? And then do you have the, and it's a costly process actually to organize the data. And we've realized that when we're building models, it's not a trivial aspect of it. So that's sort of one, I think, I think the building of the models itself and even the LLMs and all, it's getting more and more commoditized, right? So people like Epic are building models, and there are other people that are building models. And actually it's been commoditized in certain areas like imaging and all for a while. I think the problem in implementing, and that's partly my team's mission, is to translate a lot of that, whether it's a model developed by researchers or by vendors. How do you operationalize it? Does it give value to the organization, right? Is it, or you just put the model there and there's no returns to it? And so what we've learned is the problem is that of change management, and by that I mean, you will need to change clinical care paths, and let's say we can come up with models that predict certain diseases in people outside of like the standard things we do, like colonoscopies and those kinds of sort of standard procedures. Will we have the capacity in the system to then downstream handle those things, right? Like, so we can generate that. We can take the whole population and pretty easily predict certain things that to look for in people, but then how do you tackle that, right? That's one. The second is, the payers, right? The payers pay for some of this stuff, right? They have, there is this war of prior art that has been going on, and now I think, Blue Shield is building their own prior art, and Stanford is building their own prior art, and these prior arts are going to fight with each other, and now is that sort of the future we are looking for? Those are the kinds of challenges of sort of the change that's coming with AI that makes it really hard to actually implement the model successfully and get value from it. I think that's where I see a lot of the challenges.
Just to follow up on that real quick, what would your guide or approach or advice be to the room on how to approach solving that problem?
Yeah, so one of the things is, we've learned is the technology organizations also have to adopt actually, right? Which is, we are so comfortable with you give me requirements and then, do development and all that stuff. That's not how we're implementing some of these systems right now. We're like this ambient AI that even Chirag mentioned, we just rolled it out to 50 people and said, let's try. Let's put it in the workflow, let's try what happens. We did it for more than a year and learned from it, and now we are rolling it through the enterprise, right? Because we don't know how to test them. How do you test language? We have, in the benefit we have at Stanford is we have a lot of resources to collaborate with, like our computer science department and a lot of other sort of cognitive type of departments. And we're working with them to sort of figure out what the truth is and how to test against that truth. But that's still to come, right? So that's one thing, right? Which is don't be afraid of trying. Just take a risk out there, try, do it in a controlled way, and not worry about the whole release life cycle and all that stuff. Get away from all that. So that's sort of one. And just to complete sort of your question that you asked me, what I feel are things that I feel excited about that's coming is things that we have not yet imagined, and we are starting to work on that. One is sort of, what's the primary care physician of the future going to look like, right? Can we, through AI, automate a significant amount of what the primary care physician does, so the primary care physician can actually work on the complex cases and help navigate the patient, the system, which they have a really hard time doing. So for example, oh, I'm going to climb Everest, I need that much. Do you really need a primary care appointment for that, right? You need annual checkup. There are a lot of things like that when I look at what the primary care physicians do. You don't need to like make an appointment with a physician to do that. I think through some of these Gen AI tools and language models, we should be able to solve for those. And then, so I think that's not there yet today, but we're starting to think about that. That's one. The second is sort of doing precision medicine at scale. So we do precision medicine at Stanford, it's part of our mission, but it's individual, right? If I show up in the hospital, I have a critical situation, a bunch of physicians will come together and they'll get specific with me, but that doesn't scale to a much larger population, right? So imagine now a world a few years from now, before you show up at the hospital, the physician has your genetic print, they have a bunch of algorithms that have run and looked at the history of your illness, provided their physicians with a summary of where you are, so they don't have to rummage through notes and spend a lot of time figuring out for each case. Same thing, helping the tumor boards and things like that, doing a lot of the legwork that when you show up at the physician, very specific, precise to you, we have a bunch of data for them to act on, without a lot of manual work, actually. So that's kind of the kinds of things we are looking at for the future, actually, how we can help the clinical care.
Absolutely, thank you. Now, I want to move on to our audience Q&A section and then before we move on to the networking breakout. Folks here, do you have any questions for Anurang?
So, can I just start on your last point about the change in the interaction with physicians and the use of models for that? And sort of the appetite for physicians to use these models. Now, I'm going to go back a few years, the introduction of Watson, and IBM tried to kind of lead down that path. It was a very different product than it's today. But in early days in healthcare, we saw it became a demo of it, if you remember, and it held promise, but the physicians were not inclined to adopt it and use it. Like I said, it had limitations and other issues, but it seems like that's kind of an ongoing issue. You're a teaching hospital and university, and so the appetite maybe for your physicians is different than other providers out there. Comments? Love to hear from your physician.
So actually Craig can maybe talk to the adoption, but one of the things I will mention is that we had pretty healthy discussion with our dean. I think that we are going to fundamentally change how we educate the physicians actually to use AI. Like, 30, 40 years ago, people probably weren't using some technologies that they have now is a routine today, like stents or whatever, right? I think this is now going to become part of how people provide clinical care, right? So that's sort of one thing that's coming to, because once somebody's trained for 10 years in a certain way of doing things, and it's profitable and so on, it's very hard to change actually, right? So I think that's sort of where we are going to catch things is how to educate. But I think, maybe Chirag can speak more as to how he sees it from a change point.
I agree with Anurang. In my experience dealing with this, there's definitely a generation battle. Folks who are used to the way they have been doing it for 25, 30 years, and that's something we saw when we moved from paper chart to EHR. When I started my practice out of training, this is going back to 2008. I was a paper chart that I was going to do because the hospital do a paper chart, and then I couldn't wait to get the EHR EMR going, which eventually happened. At the same time, the level of anxiety I saw among the folks who are joining for practicing for 20 years, they were very stressed and they were unhappy, and some of them were unhappy until they retired, and one of them just decided to quit and retire early. So similar level of generation challenge we are seeing when I have seen when this AI alert pop-ups will come on the screen as soon as they log in, the model I was sharing earlier, which patients, level of illness or how sick they will get. They're like, well, I don't want one more alert. I don't want to deal with one more, computer can tell me. I just want to look what I want to look and be done with it. So that's that group which is going to have a hard hard time dealing with it. There's obviously another group which is more tech savvy and wants to overall have work-life balance and use as many tools as they can to get their work done, whether it's charting after patient communication, whether it's using the help to guide their care. They want to be efficient, they want to be more guideline driven, they want to be more like evidence-based and cutting-edge driven, and that group is always open. And that's something you will see in the group that Anurang mentioned, that people who are getting trained right now, or those who are training in the last 5 or 10 years, they are prepared for these changes to come. And the third group I have seen is a group which is more anxious about AI sort of taking over their work, and they will not have enough work. And that's something more I see in the folks who are in the private practice or community, where they feel like this model might come in take over their work, and they might see less patients in their office, or they might get less overall patient calls because the AI model will solve problems, and then eventually patients may not need to come to a doctor's office. They will just log in and use the AI model and get the treatment, antibiotic medications, and be done with it. So I think that group is another group where I think we need more assurance and data that AI model is not necessarily to replace, it's more to enhance, and again more to come. But we have to develop this in a way that physicians feel that this is going to be physicians or APPs or physician assistants. They feel like this is going to be enhancing their day-to-day practice. This is going to cut back their overall time they spend on charting or non-patient related work, and is going to make their life even overall better. So I think that's where we need more work and more physician input, not only from the university or academic side, but more on folks who are in the community practice or private practice or outside university practice, because that's where bulk of day-to-day work is done. Patients are coming for their day-to-day issues other than being referred for advanced care always. So that's what I have seen in my experience so far.
Thank you.
You mentioned about, again, the different groups that have reactions to the level of engagement with AI. Do you see a world where the interfaces themselves are hyper-personalized, so provider A versus provider B can tune their own interaction model? And how do you balance that personalization with standards and protocols that you need to sort of keep consistent in the hospitals?
So, if I understand the question correctly, I think the softwares themselves are starting to do that. Like, I'll give you an example of the nuance stuff we are rolling out, right? One is they're rolling out features that help you personalize based on the style of the patient, the provider, the way the provider takes notes, or how they capture information. I think one is, you do want things to be a little bit standardized, but you don't want to lose sort of the value of the provider, what they uniquely bring. So I think they're starting to do that. There's also the cosmetic part of it, like they understand you well enough and all that stuff. So this personalization is starting to happen because it's extremely important, actually, right? These are things that these are the things that personally, individual providers provide. So I think people like Nuance and other people are starting to look at how to recognize language in a very individualized way, actually. So I don't know if you have anything to talk about around personalization.
No, I agree. I think more work needs to happen there, that brings down to the same same question, because depending upon the type of practice the provider has, whether they are in a small practice on their own, a group practice, a part of a larger practice, university practice, and depending upon their specialty, their scope, whether hospital or outpatient care, I think the needs are going to be very different. So I completely agree that unless we are able to personalize this and find a way that is will add value to that particular practice a physician or a physician assistant has. And I'm mentioning physician assistant because we are seeing more and more nurse practitioners and physician assistants now practicing, and their perspective is sometimes different than what physicians have traditionally trained. So I think more personalized care will be necessary if we want this model to grow and make it more acceptable and, make it user friendly, because at the end of the day, that's what it's gonna take. It's gonna be hard to generalize one model and just shove it on folks, because that's just gonna add more burnout, more dissatisfaction, and, eventually patient care will be affected. So I really need more personalized setup for this.